Hello, everybody. Good morning, good noon, good afternoon. Happy Friday. Prof. Rez is here. Prof. Rez, um, good morning. How are you?
I am better now that I see your beautiful face.
Oh my gosh, 45 minutes of flirting left to go, but let's get started. Prof. Rez, we're in great company today. Did you know that we're in the company of Dr. Patolia's chief residents? One of whom is hiding. His name is Dennis, and the
Right.
other, Ufuk, is presenting. Would love to pass the mic to you all to introduce yourself. Tell us a little bit about yourself, please.
Absolutely. My name is Ufuk. I'm one of the PGY4 Chief Medical Residents in Cook County Hospital. Um, I'm from Turkey originally. I came here in Chicago just 4 years ago for residency. I grew up in Turkey. I like playing the guitar. I like sailing. I like running. In the last few months, I think, more. And I love medicine. And I'm not going to tell you my next destination because it may reveal the case too early. So I'll just keep it a secret for
I am
now.
Googling your name as fast as you're speaking right
No.
now.
Yeah, yeah.
Amazing. Well, what was?
Very excited to be here.
Oh my gosh, I don't know. There's so much more left to explore. I heard you saying in the breakout and beforehand that you have overlap with Dr. Patolia, and that you also have overlap with Dr. Eris. How did you get to know Tansu?
Tansu, from Society of Turkish American Physicians, we
Oh,
have like a staff community. We're pretty big. I think 200 plus people all across the United States are Turkish. And we were doing some Spanish lectures with Dr. Yasmin, actually. He was helping us. So, it's a community. And Tansu was said like, oh, CPS. I said, yeah, I've heard from Kirtan. So I decided to like listen a few lectures and I loved it so much. Like now it's part of my routine.
Robbie, can I make my first diagnosis?
yeah. Oh, please.
Oh, let me put in my Yeti mic. Well, one quick question. Where are you?
Where am I? What? You cut off, sorry.
Oh, where are you from in Turkey?
I'm from Izmir.
Izmir. Okay, beautiful. Turkey is such an amazing place. I really want to go there. But since you're my neighbor, I'm from Iran, and you're
Oh,
Robbie's neighbor from Lebanon, there's one specialty that you're headed to. And I'm going to say it now, and you can reveal it at the end of this. That specialty is going to be cardiology. But we'd love to hear from Dennis. But I bet it's cardiology. Second is going to be GI because there we prioritize money and prestige. Robbie and I are looked down upon in those communities.
no, you have the most prestige ever. I mean, it's not
Oh,
even a question.
I'm
Um,
sorry.
yeah, I genuinely love cardiology though. I really love it. And Dennis will also go to cardiology fellowship too. We're both gonna be cardiologists, hopefully.
Wow, Prof. Rez. That's incredible. By the way, no, we don't have the most prestige. My mom still asks me what kind of doctor I am and questions whether I am a doctor. So there's no prestige involved. I was just in awe of the fact that you're telling me that there's a Turkish group of physicians who are all huddled in America who are learning Spanish, and that's what's bringing people together.
Yes. Thanks to Dr. Yasmin. Dr. Yasmin taught us a lot actually, up until
I'm
now.
sure,
The
I'm
future
sure,
too.
I'm sure she did. Yeah, there's the one and only yes. Well, I think we could babble forever. Why don't we jump right in? I think Prof. Rez, since you nailed the diagnosis already, you should start.
No, you're starting, my friend.
Okay. So the title of this case is More Than What Meets the Eye. And the title comes from Dr. Patolia, of course. So this is a 29-year-old gentleman, no past medical history, presenting with abdominal pain, nausea, vomiting for 1 week. The abdominal pain is generalized. He describes this as cramping and episodic pain lasting for 15 to 20 minutes. He is persistently nauseous and has 15 to 20 episodes of non-bilious, non-bloody vomiting in the last few days. Before this episode start, he binge drank alcohol for 5 to 6 days. He visited a clinic a few days ago. He was told that he had viral gastroenteritis and prescribed Zofran with minimal relief. Then he presented to an urgent care clinic the day he presented to the ER and was found to have a saturation of 90%. And they said, just go to the ED.
Wow, this is absolutely fascinating. Prof. Rez, there's a lot of dimensions here. Maybe I can just tackle the abdominal pain and the alcohol, and then the hypoxemia actually surprised me. So maybe you can layer in how that influenced your thinking. I think what we're seeing here is really illustrative of what was so beautiful about Hans's case presentation, is something really, really common, then escalating to something that is unusual. And as we've been emphasizing over and over again, really the pursuit of diagnostic excellence requires you to not jump into the esoteria right away and be systematic in your analysis. And abdominal pain that is crampy and episodic for 15 to 20 minutes in a young, otherwise healthy person is incredibly common. And we've been reflecting a lot on CP solvers about using the VIPO mnemonic, VIPO, to help us prioritize the emergent causes of abdominal pain. Now, those are vascular for the V, I for inflammation, P for perforation, and O for obstruction. So, examples would be acute mesenteric ischemia, pancreatitis, bowel perforation, and bowel obstruction. That is in stark contrast maybe to the approach that you learned in medical school, where people tell you to use a quadrant-based approach, a right upper quadrant, right lower quadrant. And unfortunately, that approach collapses when the patient's pain is diffuse. What does it fundamentally mean when the patient's pain is not localized? What that means is that the probability of an itis, is reduced and only restricted to the bowel, because you're not going to have cholecystitis or appendicitis or diverticulitis cause diffuse abdominal pain. And when you start to think of that more and more and more, there is actually a localization for diffuse abdominal pain. There's only one thing in the abdomen that is located diffusely throughout the abdomen, and that's the bowel. So if your patient has diffuse abdominal pain, the overwhelming probability is that they will have disease of the small and or large bowel. There are exceptions. The peritoneum is diffusely located in the intestine, in the abdomen as an example, but practically speaking, when you hear diffuse abdominal pain, you're immediately thinking, what's wrong with the bowel? And this space is actually very, very simple in real life. If the patient has pan-bowel symptoms, we invoke the diagnosis of gastroenteritis. What do I mean by that? If a patient has both upper and lower symptoms, nausea, vomiting, and diarrhea, that combination is virtually diagnostic of enterocolitis. If the patient has diffuse abdominal pain, but does not have either upper or lower symptoms, you have to then realize that the enterocolitis diagnosis, the most common form of bowel disease, is probably not at play. So let me just say that one more time. Diffuse abdominal pain is often disease of the bowel, but not always. That's the first logical step. There is one very common and very benign disease of the bowel, infectious gastroenteritis. How can we pull out that diagnosis from the other sinister causes of bowel disease, which we'll review in a moment, is the presence of upper and lower GI signs simultaneously. It is that young person who is doubled over in both nausea and vomiting and diarrhea. There are very few sinister conditions that can affect the upper and lower GI tract simultaneously without the patient being peri-death. So if we're saying, oh, the patient's upper and lower GI tract is involved, but they're here in urgent care clinic, that tells you that the disease has to be mild in severity, and that's when we invoke infectious gastroenteritis. Here in this patient, pay attention. He does not have any diarrhea. That's a big red flag. And that's what takes us to think about all the other non-infectious causes of bowel disease. And that's what would make me think this person is different than everybody else. It would make me think, does this person have a vascular issue affecting his bowel, venous or arterial? Does this person have obstructive physiology, especially given the sheer number of emesis that he has had? Of course, the presence of alcohol influences our calculus and pushes us to prioritize the diagnoses that would show up immediately on laboratory testing, like pancreatitis, alcoholic ketoacidosis, and alcoholic steatohepatitis. It's not uncommon for us to send labs in patients with alcohol and find none of those three things: metabolic acidosis, pancreatitis, and steatohepatitis. And then we often invoke a diagnosis of alcoholic gastritis, which would be very explanatory for the initial symptoms this person is having. But there is a twist, and that twist is he's hypoxemic. And that probably pushes us to completely pivot. So I'm curious what thoughts you have, Prof. Rez, on this, and what the hypoxia does for you.
I want to thank you for making it so practical, Robbie, like really taking us to how you think about these patients that come into your urgent care or emergency department. Very, very helpful. And I think this story actually starts with gout and pseudo-gout. So this is an inside joke. No one else will understand this, but I had to say it for Robbie.
You, Prof. Rez.
My approach to hypoxemia is based on a thought train created by Dr. Kara Lau. I would highly recommend you just Google CP Solver's hypoxemia thought train as I discuss my approach, because previously with hypoxemia, they'll teach you the 5 mechanisms, but our minds aren't well adapted to go through mechanism of pathophysiology while we're approaching a patient. And invariably, there's always confusion between one mechanism and another mechanism. Shunting, BQ, I would ignore all of that. And if you're a pulmonologist and having a stroke right now, I'm glad you are, because I feel very strong about this approach to hypoxemia. But the first step is this true hypoxemia? Like, think about it. This guy's oxygen sat is low, and he felt good enough to walk to the urgent care. And obviously you'll see if he's in respiratory distress, but that's the first key question. Is there a mismatch between what you're seeing and how the patient appears? Because this may be a false hypoxemia, meaning the patient has Raynaud's or they have nail polish or the probe is wrong. So you have to really make sure it's hypoxemia. Once you make sure it's hypoxemia, give the patient some oxygen. If their O2 sat normalizes, then you know you're dealing with something that has a normal AA gradient, like COPD, like opiate overdose. Now, in this case, let's assume it's true hypoxemia. Let's assume that it doesn't completely normalize with 1 liter of oxygen. Now you got to ask the question, do the lungs sing? But with a little bit of a caution. The caution is this, is that when I put my stethoscopes on the lung of this patient, if I hear something abnormal, then probably I'm dealing with pathology within the thorax. For example, I hear crackles or reduced breath sounds. This would really make me drive towards the thorax, whether it's the alveoli, whether it's the pleural space. Let's say I don't hear anything. I'm not yet done with the thorax, my friends, because our ears aren't perfect. Like, our exam isn't perfect. And I'm totally okay with missing crackles. I'm totally okay with missing a pleural effusion. So in all these patients with hypoxemia, you have to get that chest x-ray at minimum. You have to get an EKG at minimum, and you may have to get an ABG in some folks. But if I don't hear anything or the imaging is negative, then I'm in that category of image negative hypoxemia. And this is when you're really thinking about shunts. And one clue to shunts is that the oxygen doesn't improve when you give them a lot of oxygen. That's really important to realize. Or are you dealing with a pulmonary embolus or something that just can't be seen on your normal imaging, and there's no parenchymal pleural pathology? Now, if we were to link this to the vomiting, Robbie, I think the easiest way to do this, but it would be odd in this, if you're vomiting so much, you can easily aspirate. And through aspiration, you can either have a pneumonitis if the hypoxemia is sudden onset, or you can develop a pneumonia. So that's one quick way I can link the two together. Or, and this is based on the sequence of events, or you have a pathology that's causing both the hypoxemia and the gastrointestinal symptoms, meaning it's causing both. So I'm really interested in hearing more from you, but I'm worried about this patient. I want to make sure the oxygen and then the JVP exam, the lung exam, those are going to be crucial.
Excellent. Thank you very much. I'll continue. No known allergies, no medication use other than Disophran that he was taking, no past medical or surgical history as we discussed, no significant family history. There is alcohol use. He normally drinks 4 to 5 beers daily for 4 to 5 days a week. There is marijuana use. He is smoking 3 to 4 times daily. I can give you the vitals and the exam and some labs. Vitals with blood pressure of 98/55 with a heart rate of 110. Respiratory rate is 30 and saturation was 88. He was worsening in the ED with use of accessory muscles. So he was placed on high flow nasal cannula. His temperature was 37.4 Celsius. On exam, he was in moderate distress. As I said, he was using accessory muscles and scattered fine crackles throughout the lungs. He was tachycardic with regular rhythm, normal S1, S2, and no murmurs were heard. Mild tenderness was present throughout the belly, the abdomen, with no rebound and no guarding. I can give you some basic labs. Sodium was 132, potassium was 4.6, chloride was 92, bicarb was 25, BUN was 23, creatinine was 2.0, sugar was 134, potassium is 4.2, magnesium is 1.7, and calcium corrected was 8.6, and the normal one is 8.1. With the CBC, WBC was 16.2 thousand, with 82% of PMNs, 13% of bands, 3% lymphocytes, and 2% of monocytes. The HB was 15.0 and platelets were 86.
Very helpful. I will leave the labs for Robbie to tackle, but just one quick question. And sometimes it's difficult to do this, and it's okay if it wasn't done. JVP, was that done?
JVP was not documented in the initial
Yeah,
initial
that makes sense. Like, I mean, this patient is in distress, is in extremis. This is very, very worrisome vital signs. If you learn anything during your intern year, it's how to tell if someone is sick or not sick. Hopefully you'll learn more than that, but that's something that's crucial to learn. And when I look at a young patient, previously healthy, with this blood pressure and that O2 sat, I'm very, very worried because young people, unlike older individuals or those with other comorbidities, they have so much reserve. So something hectic is going on in this patient to over breach his physiologic reserve. And just right away, what grabs my attention is, like, honestly, in real time, I'm saying I have hypoxemia and I have hypotension and I have tachycardia. The tachycardia is expected with the drop in blood pressure. We know he's had a lot of nausea and vomiting, so it is possible that the blood pressure is all explained from hypovolemia because I'm activating my buckets of shock. We haven't confirmed shock yet. A lactate would be really important in this patient. He does have an elevation in his creatinine, which is telling you that there is end organ hypoperfusion, presumably. But then I'm like, okay, hypovolemic, but why is he hypoxemic? That doesn't really explain that. So now I broaden to the other categories of hypotension, and those include obstructive physiology, distributive physiology. And so in this patient, could they have sepsis, a pneumonia that now is causing hypotension, hypoxemia? It is possible, but what's unlikely, why that's unlikely, is where's the fever? Like, this patient doesn't look like he's extremely inflamed. though I won't look at the labs, leave that for Robbie to comment on. But you have to be open to sepsis and pneumonia. You have to be open to it. As far as the cardiogenic etiologies, with tachycardia, hypotension, hypoxemia, it's easy to, hypothesize that something is happening in the heart with backup of fluid in the lung causing this patient's decompensation. And then we talked about obstructive, like pulmonary embolus, but it very well can be. So I think if I applied base rate to this, I would first be worried about a pneumonia, secondly about the heart, but this would just drive me to give fluid, but you just got to be cautious because this patient may develop worsening hypoxemia, but you have to be okay with that. If they're hypotensive, you have to give fluid. If they have to be intubated, then you have to intubate. If you have to give BiPAP, you have to give BiPAP. But additional data we're going to get, which will help guide our next steps in management, which will include an EKG, a chest X-ray, a troponin, a BNP, and I think that initial set of data will help triage the next steps, but I'm really worried about this guy. The abdominal pain, I don't know what to say beyond that. I don't even want to focus on that yet. Maybe we'll come back to the abdominal pain.
Yeah, Prof. Rez, I think that that analysis of is this intrinsic lung disease or is this referred from the heart is really the crux of this case, I think. And I think the laboratory abnormalities are really a decoration and not profound. I think it would be a mistake to say the white count of 16 is a diagnostic of infection in somebody who is so ill and could easily be demarginating neutrophils for no specific reason apart from just the severity of his illness. And I think you can make the same inference about the low-grade thrombocytopenia and the low-grade acute kidney injury. So the only issue that can happen with the labs is over-analysis. I think the crux of the case right now is, does this person have blood, pus, or water in his lungs? And I think that's going to be profoundly important. I think the action steps that I would be doing right now are tricky because I think we probably need to support this patient. And I agree with you. I think that a point of care ultrasound would probably be helpful for those of you who know how to do it. I probably wouldn't be doing it. And so I think that's because of out of ignorance rather than any actual issues with the test. I think that a trial of fluids is a very wise idea here. You have 10 to 20 episodes of vomiting, but I do think that you have to do it cautiously, as Prof. Rez said, and use it as a diagnostic step. What I wouldn't do is also just go back in time and ask him how he uses his marijuana, because if he's vaping, I think that will help us open the door to that hypothesis. And then in this instance, I think there's one morbid hypothesis that you should think about and treat right now. And that's the possibility that this person has rapidly progressive heart failure from thiamine deficiency. So in addition to the fluids, I would probably be giving this person thiamine right now. I'm not sure that I would be giving him any empiric antibiotics. And I'm really curious, Prof. Rez, do you think until you get more data, do you think you would be antibiosing or would you be holding off? Like what would your reflex be right now?
First of all, I love that thiamine hypothesis. Something so easy to forget, but literally life-saving. I love that idea. Honestly, Robbie, I get what you're saying, but because the patient's so sick, like if I was on overnight, I would just give antibiotics, I would culture, and then I would ask questions later. But of course, I think you would also be influenced by how the patient looks to your eyes, not what's on the screen. But I just, what's the danger of doing that? But what's the danger of not doing it, is in my mind.
Very wise. I love it.
All right, thank you very much. I can continue. Liver function tests were obtained with a total protein of 6.1 with an albumin of 3.4. T-bili was 1.6. D-bili was 0.7. There was alkaline phosphatase of 147. GGT was 70. AST was 33 and ALT was 49. LDH was 369. Uric acid was 5.2 and lipase was 3. Coags with INR of 1.14 and PTT of 31. There was hepatitis panel that was obtained that was negative. HIV was negative. TSH-free T4 was normal and respiratory viral panel was normal. Utox had cannabinoids positive as expected from history. He had a blood gas initially, which was venous. pH was 7.41. PCO2 was 41. PO2, this was before when he was placed oxygen, was 17 and lactate was 3.2. Then when he was placed on oxygen, pH was 7.35, PCO2 was 41, and PO2 was 119. This was arterial. And the repeat lactate was 2 from 3.2, I'm sorry. There was CT abdomen pelvis that was obtained, which showed cholelithiasis and gallbladder wall thickening, correlate clinically for acute cholecystitis. And there was ultrasound of the gallbladder, showed similar findings with mild gallbladder wall thickening and sludge present in the gallbladder. And other than that, no other inflammatory signs in the gallbladder. For chest x-ray, I really want to show you this chest x-ray. So let me figure out, share screen. All right, are you able to see? So this was the patient's chest x-ray. And I can give you the report if you want now or later or however you want.
Robbie, do you want to read it or do you want me to read it?
Yeah, sounds good. I can give it a crack and please jump in. I tend to really not do systematic reads of x-rays because I think real life you often don't. You are very quick, and I'll share my quick impressions. I see bilateral interstitial infiltrates predominantly in the right lower lobe, but also on the left. There seems to be a little bit of perihilar congestion, but there's no cephalization that I can see. There's no effusions, and the heart is not enlarged. Those are my reflex thoughts. What do you think, Prof. Rez? Oh, and the bones, by the way, let's not, I don't care about the bones. Oh my gosh. What was your read? Yeah. Oh, no. What was your, yeah.
Absolutely. Yeah. So the report shows exactly the same bilateral lower lung airspace and interstitial opacities, more prominent on the right, concerning for an infectious/inflammatory process. That's exactly the report is.
Super intriguing. I think it's interesting to analyze the nature of the data you obtained, and maybe Prof. Rez, I can reflect on the rest of the labs and then pass the imaging to you. If you were going to try to predict what the X-ray shows, I think the gas analysis helps you do so, and that we know that the patient is initially hypoxemic, but then with oxygen correction, his PaO2 goes up to 119. And that tells you that this patient does not have prominent shunt physiology, and the probability of you seeing something on his X-ray is very high. In other words, if you're able to overcome the hypoxemia with oxygen, you tend to localize the issue not to the vascular space, but rather to the alveolar side of the alveolar vascular interface. And the rest of the labs are really illuminating with regards to the abdomen, and I think almost predict the CT finding of NOS. I think the fact that the UTOX is positive for cannabinoids emphasizes the relevance of this substance to our analysis today. But let's remember two things. The base rate of cannabinoid use in the general population is through the roof, and so it may be true and unrelated. But it may be an important feature to hold on to in this context for the possibility of vaping-induced lung issues, but also because of the possibility of the contribution to cannabinoid hyperemesis syndrome, which of course is a very, very problematic, but also can predispose to nutritional deficiencies by the sheer amount of vomiting that patients can have. So it's hard to know if the cannabis is of relevance because it's so common, but I think a syndrome of pulmonary disease should make you think and wonder about vaping. And a potential cardiac disease, though the lack of cardiomegaly on the X-ray makes that less likely, should make you think hyperemesis and wonder about thiamine deficiency. So the labs, again, are little hints that you want to use but not overanalyze. What do you think of the imaging, Prof. Rez?
I'm still in awe of you just keeping track of all the data that preceded the labs and imaging and the comment about the marijuana. I think this is where clinical reasoning really helps you make progress. on a prioritized differential diagnosis. Like, I want to give this exercise to the audience. If you were to summarize this patient's presentation, what would it be? Like, what words would you use? And words are so powerful in thinking because they allow us to frame, and then they allow us to create prioritized DDX. And sequence of events is important, but what I want to focus on is just this chest X-ray. The chest X-ray with this degree of hypoxemia reflexively makes me think of acute respiratory distress syndrome. And acute, it makes me think of acute respiratory distress syndrome. And acute respiratory distress syndrome is really non-cardiogenic pulmonary edema. So always on that differential diagnosis is, does the patient have pulmonary edema from a cardiac source? And here, there's a few clues that push us away from a cardiac source. And that is, one, the size of the heart, but you have to be okay with acute heart failure having a normal sized heart because that left ventricle is so strong and it's not going to just blow out immediately. The lack of pleural effusions, but that too is okay because it takes time to develop pleural effusion. But if you look at that X-ray, it just doesn't look like that fluffy edema that we usually see with heart failure. And this patient doesn't even have a history of heart failure. The JVP isn't distended, but I would still send the troponin. I would still get a BNP. I would still get an echocardiogram, but I think cardiogenic pulmonary edema is less likely. So now I'm saying, okay, acute respiratory distress syndrome and its mimics. And ARDS, when you think about it, the most common causes of ARDS, and this accounts for 80% of ARDS, include sepsis, aspiration, pancreatitis. These are the most common etiologies. And really what's happening is you're just getting an insult to the lung, and that insult is causing leaking of those capillaries. And you get leaking of fluid, and then there's a fibrotic phase. And you can use the PA to FiO2 ratio to categorize the severity of ARDS. So if that PA, like what's happening in the patient's blood, arterial oxygenation, is low and the FiO2 is high, what you're giving the patient, then you know it's severe ARDS. So I have to run that list. We don't have a history of pancreatitis, but this would prompt me to send the lipase. Like, he's been nausea, vomiting. Could this be pancreatitis? Possible. That lipase will be helpful. But the CT of the abdomen and pelvis didn't reveal pancreatitis, but you have to be cautious because early on it may not show anything. The other thing is, there is really, again, like sepsis, I would still treat with antibiotics, but it doesn't seem likely. But I would get blood cultures. I would get a procalcitonin. Aspiration is a possibility, but boy, this would be quite the response of this guy's lung to aspiration. And presumably he has good cough reflex and good pharynx, and he's not altered. So why would he be aspirating despite vomiting, though it's possible? It's possible. But the ARDS mimics is where it gets really interesting. And that's where you have conditions like eosinophilic pneumonia, hypersensitivity pneumonitis, diffuse alveolar hemorrhage, E-Valley, which Robbie was alluding to, which it has to do with the vitamin E, like irritating the lungs. And this was first shown, I think, like 3 or 4 years ago. But it's a diagnosis of exclusion. You can't lead with that hypothesis. So, Robbie, what the X-ray does for me is, like, first and foremost, I want to make sure it's not cardiogenic. Second, I want to make sure I'm not missing an infection. So that's where cultures and et cetera will happen. And then third, I would watch the trend of the CBC, make sure that hemoglobin doesn't drop. And then I would want to exclude everything before I land on the diagnosis of vaping-induced lung injury. Any comments on that, Robbie? Anything else you would be doing as like an ED doctor beyond like this initial workup? Oh, you're muted.
Oh, that's right. You silenced me and Nara. Good to it like really shut him up. So thank you. I am no, I don't. I think the question that I'd be grappling with is before this patient goes up to the floor, should we get a CT chest to really understand what's happening in his lungs? And I think the 10,000-foot view of this case, if I just share my mental summary of it, is a young and otherwise healthy person with some risky substance exposures that we're tracking both as an inlet to his heart with thiamine and as an inlet to his lungs with vaping. That's really the background risk factors that he seems to have. And he came in with a thoracic and abdominal syndrome. And the thoracic dimension is one that has left more of an imprint on us with his x-ray being positive. And the abdominal syndrome has been relatively underwhelming in its nature. And so the question is, should we try to understand the lead that we're getting better with cross-sectional imaging? I think the value of the CT scan might be diminished if his BNP comes back at 2,000 or if his IVC is plump on a bedside ultrasound. But it might offer value by the presence of consolidations over GGOs, because consolidations would be relatively unusual for pulmonary edema. So that's what I would be thinking of before I think the patient leaves the emergency room. I'm still at the tension between what is this fluid and worried that it's either water or some substance. So I think the CT chest might be helpful.
You know, one thing I just want to share, it's crazy, man. Like I haven't thought about this eValley for so long, but at one point I had spent, I want to say hours in creating this thing,
Probably
but I
did.
just want to show you, bro. Does that happen to you when you don't visit? And that's, I think, the advantage of doing all these cases. Are you seeing this diagram real quick?
Yeah,
So
yeah.
I want to just show this illness script of eValley for those that aren't, 80% is less than 35, acute in onset, questionable THC, vitamin E, it's acute lung injury. But I think what's really important is you got to exclude the other causes, and we got to send a respiratory viral panel, and already thinking like, I'm going to give him antibiotic, but considering glucocorticoids so it doesn't, progress quite rapidly. Not that I'm there yet. I'm just priming my mind. What's your joke?
Oh, no, since you have it up, look at the other category, the GI category, nausea, vomiting, diarrhea.
Yes. Oh shit. So that too. Maybe in another 20 hours with it, Robbie, I'll remember it.
I think you'll remember it for life now, Prof. Rez. All right, Mike, to you, my friend.
So a CT chest was obtained. I want to show you this. So I'm a very visual person, as you may have understood by now. So I put like empty slides in between so you guys don't see the rest of the.
Oh, such a strategic case presenter. I love it.
Okay, so this is the CT chest. I'm gonna give you the report right away, but I just wanted to show the picture too. There you go. There you go. So the report is new consolidative and worsening ground glass opacities in the lung basis compared to the CT abdomen pelvis from earlier today. Someone said the lower lungs, can we look at the CT abdomen pelvis? The radiologist contrasted that from the CT chest that was obtained about 4 hours later in the ED. And they say it's worsening. And there's additional opacity in the right upper lobe too in the CT chest.
Yeah, well, I think that's so helpful in that it just really prioritizes a rapidly progressive process. Rapidly progressive. It's not stopping. It's not putting the brake on. And I think this really lessens the likelihood of stuff that has pleural effusions like heart failure. And I'm right there I'm right there with ARDS and its mimics, and I don't have a good reason for ARDS. And I think eValley, Robbie, is becoming very, very plausible. But I would still get the infectious viral panel and SARS-CoV-2.
Yeah, so viral panel.
Or did you have more? Oh, you had more information for this alcohol. Sorry about that. Please go ahead.
Yeah, no, that's okay. We can discuss because the more like, yeah, we can.
Oh, no, I'll just share it, Professor. Isn't it so cool just to reflect on our thinking? Like now I think the heart is so much less likely because we're seeing consolidation. So I'm right there with you. I think now we're solving a predominantly lung problem with the clues being leukocytosis, GI symptoms. But it's so cool to have made that progress and just really reinforces the rule of when to get X-ray over CT. Like if you think it's CAP, or if you think it's heart failure of a pneumothorax, CAP, heart failure pneumothorax, you should get an x-ray. But this case wasn't screaming any of those. And it's really cool to have made so much progress with the CT scan. All right, tell us more.
Absolutely. Excellent. Thank you very much. So EKG showed sinus tachycardia. Troponin initially was 0.147. The repeat one was 0.191, and the repeat one was 0.160. B Nancy P was 1,532, 1532. He was admitted to the unit, to the ICU, was started on sepsis antibiotics, likely pneumonia in the note. However, respiratory status worsened overnight. Remember, he needed high flow nasal cannula. Now he had to be with endotracheal intubation.
I take back everything I said about the CT scan. I think this case is more than meets the eye, Prof. Rez. And I say that because I think the real life tension of heart and lung, heart and lung, heart and lung. I think that with that BNP, you really have to step back and analyze this case as the possibility of a cardiac component. So maybe I can just reflect on the heart dimensions of this, and then pass the mic to you to add to that, and then reflect on what if the heart is just a distractor and it's actually in the lungs. But I think there are some actionable things with regards to the heart. And I'm very grateful for Nidhi, who presented a case of rapidly progressive heart failure last week, and I've spent too much time thinking about that. But you should have a little bit of a checklist when somebody develops florid heart failure, if this is in fact the case. And of course, I think a bedside ultrasound, JVP and IVC assessment will help predict that. But this finding should push you in that direction. And ultimately, when you're trying to figure out if why a patient has heart failure, I recommend you break it down into two causes: an issue with the myocardium or a mechanical issue. A mechanical issue may be something like a VSD from myocardial ischemia, or a flail mitral regurgitation, or something that you can picture and visualize with the echo probe. Myocardial issues are most often related to acute coronary syndrome, which this patient probably does not have based on the EKG and his age. And after you really reduce the probability of acute coronary syndrome, should you think about myocarditis and peripartum cardiomyopathy. Those two things are probably not at play in this patient. Peripartum cardiomyopathy is definitely not at play, and myocarditis is possible, but you have to only think of that after you think of the 3 T's. Thyrotoxicosis, which has been ruled out in this patient. Takatsubos, which doesn't make sense for this patient's age and gender. And then finally, thiamine deficiency. So if I had forgotten to give thiamine before, I would definitely be giving double the dose now. And I would be giving it for 2 reasons: alcohol and the risk of thiamine intake being reduced, but also marijuana, hyperemesis, and thiamine loss, as occurs in hyperemesis gravidarum. So this patient needs, I think, an echo and needs a whopping amount of thiamine. But I am not sure that the heart is really the problem here, and would be pursuing the lung hypotheses in parallel. So I'm curious, Prof. Rez, what are you thinking about the heart, and what stuff with the lungs are you still tracking?
Dude, every time you share a data point, I'm not even joking. I'm like, wow, they actually get, like you said, the TSH was normal. I was like, wait, we had a TSH. So I'm just so grateful for you being here, for capturing from the title to the marijuana to the I don't know what's going on. But I had one question, just the troponin trend. Was it 0.147 and then it was what? And then 0.16?
Yes, 0.147, 0.191, and 0.160. So
Okay.
it's mildly elevated and stable, I would
Got
say.
it. That's super helpful, because the troponin kinetics can tell you a lot about what might be driving it. I think what's really important is to realize this, and we've made this point so many times on CP solvers, is that you can have multiple stuff happening at once. Meaning you can have ARDS and you can have insult to the myocardium. This is where you have to apply the law of proportionality. You say, let me see, does that amount of heart damage explain what's happening in the lungs? And Robbie, it doesn't, because we already know the appearance of what's in the lungs is not consistent with what we often see for pulmonary edema. You said consolidative. That's much different than, you know, these opacifications that we see. The echo will help confirm this hypothesis even more. Like if that EF is normal and there isn't much diastolic dysfunction, there's a disconnect between the degree of pathology within the lungs and what we're seeing in the heart. But I don't think the heart is completely a bystander and benign. And I'll tell you why. This is a 29-year-old guy. Presumably he has normal coronary arteries, and presumably he should be able to have a heart rate of 110 without leaking any troponin. This troponin on the high sensitivity assay is around 147, and one for people that use the high sensitivity troponin assay. So this is a real troponin leak. This isn't like, you know, Robbie, you were talking about like the UA in an elderly versus younger patient. You're like, why would a younger patient have bacteria in their urine? That's much different than an older patient who may have bacteria. So I would ask the same question. Why would a young patient have a troponin elevation? We have to get to the bottom of this. The echo will be helpful, but I have one hypothesis. It might be a little weakened. Could you have myocardial inflammation that's causing low-grade myocarditis? And I only am saying that as a possibility because in Baltimore, when people would use K-Spice, they would have myocarditis from that variation of marijuana. Like the adulterant with that marijuana would cause a troponin elevation. Regardless, we'll get the echocardiogram. I'm still concerned for E-Valley, but could cannabis explain the hyperemesis, the E-Valley, and maybe some myocardial damage? But very much agree that we have to give this patient thiamine. And if the echo is like an EF of 10%, then maybe you have tachycardia, high LVEDP, and other stuff causing demand. But the kinetics of the trope, the age of the patient, no other etiology, I'm really worried about that myocardium. And whether it's thiamine deficiency or inflammation from the adulterant with the substance, a toxin.
Prof. Rez, I love that. And I just want to sprinkle in one reanalysis that I just did in my mind, which is the gallbladder wall thickening now. I'm wondering if it's venous congestion from the heart rather than stone disease, which we have danced about a long time ago. So now starting to like see that with the BNPs, just making us my advice to everybody is now like reanalyze everything with the heart hypothesis. It's making me dizzy. I'm really curious how Ufuk can orient us again.
Absolutely. Thank you very much for the comments. So an echocardiogram was obtained. I'll again share the screen. I'll be quick. I know I'm running out of time. So this is the screen for the echo. So what I'm going to do is to play these. Maybe. Can you see it now? Okay. So if you looked at it, I can give you the report. Mitral valve had flail motion that is involving the middle scallop of the posterior leaflet due to rupture of one or more cords. Now I'm sharing the PowerPoint. There is probably severe regurgitation, which is eccentric and anterior towards the septum. And there was TEE that was obtained, which is, I wanted to show you the picture. So this is the left atrium, left ventricle. This is the posterior leaflet, and it's flailing here, as you can see. And in TEE, it's much more crisp clear because we're closer to the left atrium. And now we're going to see it flailing towards this side because we're looking from the back, and the probe is looking at the left atrium. And here is the TEE. As you can see, these valves do not coapt at all. And the posterior leaflet, which now in this view is seeing P2, there's a jet that's going, that is away from the leaflet that is affected. It is going towards the septum, this jet. So it is a severe acute MR.
Oh,
So,
yeah. Sorry, I was looking for my notes. First of all, I still, this is fascinating, Ufuk, and it tells you how quickly things are unfolding in this patient. And especially with mitral regurg, you can get unusual patterns towards the upper lobes of, opacification. But Robbie, I really don't think our reasoning was off, like, because you need data and the data helps dictate the next steps. When this patient came in with hypotension, tachycardia, hypoxemia, we were worried for something happening in the heart that could explain the hypotension and can explain what's happening in the lung. Then we got more data, and really, I think the echo, which that was like the main pivot point in this case. So now all of a sudden, you wonder, like, this nausea, the vomiting, could this, this is what's happening, I think. First of all, it's unusual for someone this young to have this kind of valvular insufficiency. If you step back and you ask the question, what can cause valvular insufficiency? The DDX for that is a vegetation, which we know is not the case for this patient, ischemia, and ischemia of the papillary muscles and the structure that supports the valve. The chordae tendineae, the valves themselves get their oxygen supply through the blood flowing over, but the chordae tendineae and the papillary muscles, so ischemia, trauma, and of course, rheumatic heart disease can lead to valvular insufficiency. Now, in this patient, he's had a week of symptoms, the nausea. So could his nausea, vomiting, abdominal pain all have been his initial manifestation of acute myocardial infarction? We don't really see this complication of MI unless the MI is not revascularized immediately through a PCI or thrombolysis. So usually when someone is experiencing any kind of chest pain, they come immediately to the hospital, they get revascularization, and that prevents the complications of acute myocardial infarction, one of which is acute mitral regurg. Another is you have a ventricular aneurysm rupture that can occur, or a ventricular septal defect. So I think in this case, if there's no endocarditis, no trauma, and it seems like based on how it appeared that it was an ischemic insult, and the posterior valve is more vulnerable because of the way the anatomy is, the circulation, then the question becomes, why did he have an MI? And he's so young. And it's a young patient, you have to go beyond the base rate of atherosclerosis. You have to think vasospasm, dissection, embolic phenomenon, and unlikely Minoka. So I don't know, Robbie, I'll throw it back to you, but I'm wondering if this is a very unusual manifestation in a young guy. And the one other category I forgot to mention was like collagen vascular diseases like Ehlers-Danlos, Marfan, where you can have issues with the valve. But if on echo, it looks like this is an MI, acute MI, I would think it's a complication of it, Robbie, from not being diagnosed earlier in the week. And I think right now, you got to rush to the cath lab. You got to do a coronary angiogram. You got to put in LVAD, maybe an Impala, and you have to think, and you have to repair this thing. If you don't, this patient will die.
Yeah, Prof. Rez, I think it's really interesting I think the case of ischemic posterior papillary muscle rupture causing cardiogenic shock is the overwhelmingly likely diagnosis at this point. And I think it's helpful to take a minute to be like, well, how could you have teased that apart from the get-go? Amongst all the noise of the age of the patient, the lack of overt risk factors, the abdominal presentation. And I think it just goes to show you that the ethos of VMR of trying to get to the answer as quickly as possible may be counterproductive in real life. And that in real life, you have to be cautious and meticulous about not trying to rush to the answer, but to walk your way there. And I think whenever you have a patient with a positive x-ray, always anchoring yourself in, is it pulmonary edema, is it pneumonia, or is it an exogenous substance is really important. And to realize that diagnosing rapid heart failure, hyperacute heart failure often relies on many data points. And here, I think the troponin and BNP really changed our calculus. And so, gosh, I'm really excited to learn from Ufuk about how you all put this together. But I think, yeah, the working diagnosis is probably going to be a mechanical complication of acute coronary syndrome. Very, very enlightening. Definitely more than meets my eye for sure.
And Robbie, can I just say just two other quick comments? I know we're almost at the hour, but I just want to say, because I made this comment, that the posterior medial papillary muscle has only a single blood supply, while the anterolateral papillary muscle has dual blood supply. And you might say, wait, Ufuk, why didn't you guys hear a murmur? Well, the truth is, in 1/3 of patients, a murmur is either absent because of the equalization of pressure between the left ventricle and the left atrium. And then the other reason for that is people on mechanical ventilation, it's hard to hear murmurs. This patient's coming in hectic. So I just want to say you cannot judge any provider for not hearing a murmur in this case. Thank you, Ufuk. What a case.
Absolutely. You're welcome. Thank you for all the beautiful comments. So a left heart catheterization was done with clean coronaries. IABP was placed because patient was going into a cardiogenic shock. Blood cultures grew 2 bottles of H. parainfluenza, Haemophilus parainfluenza, biotype 1. Patient underwent mechanical valve replacement surgery the next day with good results, successful extubation. A few days later, all the lung stuff went away, and recovery period and discharge in post-operative day number 18. Pathology showed cardiac valve tissue with vegetations, with purulent inflammation, myxoid degeneration, paravalvular abscess, and the purulence was extending to the left ventricular wall.
Wow. I mean, I don't even know what to say. I think this is absolutely humbling. And I think so you said that the organism was I'm sorry, I missed the
Haemophilus parainfluenza. So it's part of the HESEC one. The H is Haemophilus species.
Absolutely fascinating. Gosh, I think that I don't even know what to say. It's absolutely humbling. I'm glad, Prof. Rez, we were able to make it to the mitral to the mitral valve. I think that I think each, gosh, I'm trying to see with the sake of time what to reflect on. I think each valve has its own unique complication that can cause acute failure. So, for example, when the aortic valve is acutely regurgitating, we have to think about acute aortic dissection. And for when the tricuspid valve does that, we have to think about external trauma. However, what all valves have in common is they can all acutely fail from endocarditis. And so I think it was really important in this patient to do the sequence that you all did, which is to cath the patient first, because ischemic papillary rupture appeared initially more intervenable and more addressable. In reflection, I think the way that I might be inclined to put this together is to wonder whether this person had myxomas degeneration or some vulnerability of his mitral valve that caused seeding of it to the HASIC organisms. But it's a humble reminder that patients can get infective endocarditis without any overt risk factors for it. And the HASIC organisms are very unique in their ability to often affect younger and otherwise healthy patients. So a massive, massive curveball here at the end, Prof. Rez. What are you thinking?
I just want to ask, just to get clarity, Ufuk, is it thought that this was just endocarditis, or did he have like septic emboli of the small tributaries causing ischemia to the valve and then valve rupture? But it seemed like the vegetation was very small. Like, was it just blocking blood supply, or was it actually damaging the valve?
It was damaging the valve, but not only the valve. The striking part is the subvalvular apparatus. The chorda tendinea and the papillary muscle were ruptured, so the valve was flailing, even though we are not seeing much on the valve, even in a very crisp TEE picture. But in the pathology, they say valves has also vegetation, but these are likely small. We just couldn't see it. But what it did, it destroyed the subvalvular apparatus to cause that eccentric MR. And when it's so eccentric, because we have 4 pulmonary veins, the jet can go to preferentially, for example, right lower pulmonary vein and increase pressure there, and it may mimic an asymmetric pulmonary edema presenting like pneumonia, like septic pneumonia, fever, one-sided pulmonary edema, but you can miss it. That was the point, especially with the murmur too, because of the left atrial pressure equalizing, because it's so like acute and it doesn't have the compliance to get large.
I regret one thing today, speaking too much, because what you just said in 30 seconds was more profound than what I said for the well, my babbling, Robbie. You got to keep me quiet from time to
Oh
time.
my gosh, Prof. Rez, I think this case is just unreal. There's so much learning here, but I just want to hear from you, Ufuk. Like, just teach us more. What was this case like for you to experience? What are the big takeaways that you had from it? Keep talking.
Yeah, absolutely. So the big take that I had is that this patient was not diagnosed till we get the TTE, and the TTE was done next morning. So point of care ultrasound was not done, and this patient came to the unit overnight. And the first note says sepsis, pneumonia, I'm giving antibiotics, but the patient worsened and worsened. And one more thing, this patient's pulmonary edema is very typical of acute MR. The subpleural sparing that we saw in the CT scan, if you look at acute MR and pulmonary edema, you will see pictures like that. I don't know the exact mechanism. Maybe it's because more central pressure overload, but like typically periphery is more spared in MR. And yeah, patient did really well. And infectious disease doctors thought, like, where did this HISEC come from, this patient? So they thought maybe because of alcohol, binge drinking, vomiting, patient aspirated because it's a gram-negative organism. It's like gut flora, they were thinking. So we don't have a clear cause of how this bacteria entered the bloodstream and kind of hung on to the mitral valve. But the poor guy, I thought he was going to die, you know, is like worsening, intubation until we get the echocardiogram in the morning, and everything was clear afterwards.
Robbie, can they delete our discussion for this case? I think so.
Oh, look, Prof. Rez, I accidentally canceled the recording.
Rumor has it Prof. Rez is still talking about eValley and showing a script he created.
Oh, you know, this is the joy of the discussing these cases. We learned so much. And for those of you thinking that RR don't learn, we learn more than everybody every day because we get to do this and sometimes get it right. And even then we're learning, but especially when we're not even close. And even when we're like, oh yeah, this is ischemic mitral regurg, we're not even close. I just want to share one fact I pull up in my Evernote, which is the average age of endocarditis, infective endocarditis in all comers is 61 years old. Makes sense, right? That's the patients we see. And of course, the average age is reduced by patients with injection drug use. The average age of endocarditis in patients with HASIC organisms is 40, most of whom do not use injection drugs. So if you're invoking endocarditis outside of injection drug use, and in a patient who's young, you should think the HASIC organisms. And I had not remembered this fact, but I think it's another dimension to tie in this case. Most patients are usually otherwise healthy, and it may not be the case in him. It may be from his vomiting and whatnot, but I don't think you even need that to loop in the HASIC organisms as an explanation. I could talk forever and ever and ever. Ufuk, this was a real treat. Thank you so much. Prof. Rez, I apologize. I have to go now to make it for round, so I'll make you the host, okay?
Thank you so much, Ravi, for coming.
Yeah, Ufuk, this, like, honestly, I love this case so much. It's like just bread and butter medicine through and through. And it seems Cook County is doing something right with all you brilliant clinicians out there. Kirtan, you, oh my gosh, that's the top place to go.
Kirtan is something else. Is some another level. I have never seen anyone like Kirtan in my life, and probably I will not for some time. Is something else. He's a great friend of mine. I always ask him cases, you know, it's like a consult, like Kirtan consult, like when you don't figure it out. Like if I have, let's say, 14 patients in my unit, 12 of them, I know the diagnosis and the treatment. And there's those 2 that I don't know what's going on. So I discuss with them. So yeah, it's an amazing place to be.
Thank you so much. Well, we have some teaching. Let's hear the case recap. Appreciate you. Amrit, are you ready?
Yes. Thank you so much for this amazing case. That's really incredible, and I'll have to listen to the recordings again. So initially we had a
No,
patient.
no one's allowed to listen to it again. I'm joking.
The discussion was fantastic, and I learned a lot. I'm sorry, I learned a lot. So it was definitely something more than what met the eye. We had a patient with abdominal pain, and we thought initially to rule out the emergency causes with the VIP or pneumonic, vascular inflammation, perforation, or obstruction. So we thought that this patient had diffuse abdominal pain, which was not localized. So therefore, probability of a localized itis is reduced. What is diffusely located throughout the abdomen? It's bowel or peritoneum. So therefore, we immediately think that there's something wrong with the bowel because of the diffuse pain. And the presence of alcohol history in this patient makes us think about differentials like alcoholic ketoacidosis, pancreatitis, steatohepatitis, and which we can understand from the labs which will be incoming. And also because of the alcohol history, we were suspicious of thiamine deficiency. And this patient had cannabis use history as well. So the excessive vomiting could be a result of cannabis hyperemesis syndrome. And we also thought it's important to ask for the history of vaping because of the presence of shortness of breath in this patient, and because vaping can affect the lungs, causing ARDS. Then we had a teaching pearl which said that nausea, vomiting, and diarrhea. Vomiting and diarrhea, that is both upper and lower GI symptoms. When they are present simultaneously, they then make us think of an GI infection. But if only one is present, for example, in this case, there was absence of diarrhea, it made us think of some other causes of bowel disease apart from acute gastroenteritis. And then we saw that the patient had hypoxemia, which we thought that we have to rule out if it's true or false, which we can understand from the patient's appearance, if the patient is in distress or not. So what could be the causes of false hypoxemia, Raynaud's, a nail polish, or the probe set in the wrong direction? And then we thought, what could be our next steps to evaluate the patient, to auscultate the lungs, to look for any crackles, a chest X-ray, EKG, ABG, troponin, and BNP. Because we were confused, what was the cause of the shortness of breath? Was it heart or was it the lungs? And we were thinking, was there blood or pus or water in lungs if it's a lung cause? And we suspected ARDS from chest X-ray, and we thought about the three main causes for that: sepsis, aspiration, and pancreatitis. And because of excessive vomiting, we suspected aspiration. But we have to, it was important to rule out a cardiogenic cause of pulmonary edema. And then we saw the low blood pressure, so hypovolemic shock was suspected. So we thought lactate would be helpful. And even the elevation in creatinine could indicate a pre-renal AKI. But we also cannot really rule out septic shock or a cardiogenic shock. So we thought a trial of fluids will be helpful in diagnosing as well. And again, we thought about thiamine because of suspected heart failure due to deficiency of B1 vitamin. And then we saw that we thought that a chest X-ray is helpful in community-acquired pneumonia, heart failure, and pneumothorax. That was another teaching pearl. And then again, the question was, is it heart or is it lungs? So we just thought that if it is an issue with myocardium, it could be due to an ACS, myocarditis, or peripartum cardiomyopathy, or is it a mechanical issue? So Dr. Rabih taught us about 3 T's, that is Takotsubo, thyrotoxicosis, and thiamine deficiency, which can lead to these symptomatology. And then we again thought that we need echocardiography to confirm our diagnosis. And we thought that gallbladder thickening could also be due to congestion from the heart. And ultimately, we saw that the patient had mitral regurgitation, which was really surprising in a young patient. So we thought, what could cause that? Is it a vegetation, or is it ischemia of the papillary muscles or chordae tendineae, or was it trauma or rheumatic heart disease? So all the differentials came to our mind. We could also think about a collagen disease like Ehlers-Danlos syndrome. And ultimately, we realized that it was, in fact, a Hessic organism causing the endocarditis, and basically that is causing the mitral regurgitation, leading to the cardiogenic shock. And we've also just a recap about the papillary muscles, the anterolateral, which has dual blood supply, and the posteromedial, which has singular blood supply. So this was a really, really amazing case, very educational. Thank you very much. And thank you for the honor of doing teaching points today.
The teaching was phenomenal, seriously, like so brilliant. I learned a great deal. Ufuk, you should sign us out. I just want to say I'm going to go home. I'm going to curl up under my blanket and I'm going to ask the question, why did I choose internal medicine?
No, thank you so much for the opportunity. It was amazing meeting you. And it's been a pleasure. I can show you one more picture that I forgot to show. This is a nice picture, I promise.
As long as it's not of E-Valley.
Just it's not a value, it's about the heart. So this was from Braunwald. So the idea that why not acute MR does not have murmur is here. The murmur is there, but it's very like in the first half of the systole, because left atrial pressure rises up significantly in acute MR. And this picture, I will not forget this, because look at this, left atrium is almost ventricularizing. And here in the chronic, left atrium is 20, 30, but here is like 80, 90, almost ventricular. So this is the last picture that I wanted to show. And thank you so much for everything.